Hello everyone, welcome to another lecture on medicine with Faizan. In today's lecture, I am going to teach you how to interpret liver function tests in the most simplistic fashion. There are three patterns of LFTs derangement. There can be isolated raised bilirubin, there can be cholestatic pattern, and finally there can be hepatocellular pattern. Let's discuss them one by one. If only bilirubin is raised and all other biochemical profile including ALT, AST, ALP is normal, then we need to check complete blood count. If CBC, the complete blood count is normal, then think of Gilbert syndrome. Incidence of Gilbert syndrome is like 5 to 8% in general population. The patients of Gilbert syndrome are mostly asymptomatic. Jaundice in such patients appear only during stress, dehydration, infection, starvation. If there is low hemoglobin on complete blood count, then think of hemolysis. If that's the case, then MCV on complete blood count will be normal, and then you will have to order lactate dehydrogenase LDH and reticulocyte count, and both of them will be high, and finally heptoglobin will be low. All these findings will collectively confirm that the raised bilirubin is most likely due to hemolysis. Remember that in the case of isolated raised bilirubin, if there is only unconjugated hyperbilirubinemia, then we are most likely dealing with Gilbert syndrome. And if there is conjugated hyperbilirubinemia, then we are most likely dealing with either Dubin-Johnson syndrome or Rotor syndrome. Both of these conditions are quite rare. Let's discuss the second pattern, that is cholestatic pattern. In cholestatic pattern, alkaline phosphatase, that is ALP, and gamma glutamyl transferase, that is GGT, are predominantly raised. ALT and AST can be raised too, but there are only minor elevations in them. In cholestatic pattern, the R value will be less than 2. To calculate R value, we divide the patient's ALT by upper limit of normal ALT value, and we also divide the patient's ALP by upper limit of normal ALP. Then we divide the ALT value by the ALP value. The result we get is R value. For example, if the patient's ALT is around 140 and the upper limit of normal ALT value is around 35, then we divide 140 by 35 and that would be around maybe 4. If the patient's ALP is around 520 and the upper limit of normal ALP is around 130, then we divide 520 by 130 and again the value may be around 4. Now we divide 4 by 4 and the result will be around 1. This R value, that is around 1, shows cholestatic pattern. So again, if R value is less than 2, it indicates cholestatic pattern. If R value is greater than 5, it indicates hepatocellular pattern. And if it is in between, that is more than 2 and less than 5, then it indicates mixed pattern. Now cholestasis can be due to drug-induced liver injury, also known as DILI. The drugs causing this pattern can be oral contraceptive pills, steroids, flucloxacillin, and cotrimoxazole. Other causes of cholestasis include biliary obstruction, for example gallstones or CBD stones, or in fact pancreatic cancer. Another cause of cholestasis includes primary biliary cholangitis, PBC. It is 10 times more common in women, and the typical presentation will be of a woman, a middle-aged woman with lethargy and pruritus. The antibody most commonly associated with PBC is antimitochondrial antibody. Also, there will be raised IgM antibodies. Another cause of cholestatic pattern includes primary sclerosing cholangitis, PSC. PSC is commonly associated with ulcerative colitis, and approximately 80% of primary sclerosing cholangitis patients have concomitant ulcerative colitis. Priyanka might be raised in primary sclerosing cholangitis. MRCP or ERCP are diagnostic for this condition. Finally, in the third pattern, that is hepatocellular pattern, ALT and AST are predominantly raised as compared to ALP and GGT, which can also be mildly raised, but not predominantly. R value, as we just discussed, in hepatocellular pattern is more than 5. Common causes of hepatocellular injury include paracetamol, the most notorious. Other drugs that can cause hepatocellular injury include antituberculous drugs, methotrexate, nitrofurantoin, and phenytoin. Viral hepatitis can also cause hepatocellular injury, and in viral hepatitis, the elevation in ALT will be more than the elevation in AST. History and serology will confirm the type of viral hepatitis. Remember that in liver cirrhosis, ALT and AST can be normal. Alcohol-related liver disease, ARLD or just ALD, can also cause hepatocellular injury. There will be history of excessive alcohol consumption, and the rise in AST will be higher than the rise in ALT. In fact, if AST is double the value of ALT, then it is quite sensitive for alcoholic related liver disease. Another condition that causes hepatocellular injury, and it is quite common in especially developing countries, is non-alcoholic fatty liver disease, NAFLD. There will be history of obesity, high BMI. The patient might be suffering from some sort of metabolic syndrome like diabetes, hypercholesterolemia. NAFLD score or FIB4 score can be used for further assessment in non-alcoholic fatty liver disease. And finally, autoimmune hepatitis can also cause hepatocellular injury. One thing that is most important in autoimmune hepatitis is the history of other autoimmune diseases. Like if the patient is suffering from autoimmune hepatitis, they may also be suffering from other autoimmune diseases like some sort of thyroid disorders, like grave diseases, and so on. In autoimmune hepatitis, anti-smooth muscle antibodies or liver kidney microsomal antibodies may be positive. To differentiate between different causes of hepatocellular injury on the basis of LFTs, just remember that the ALT and AST in conditions like alcoholic or non-alcoholic fatty liver disease are in the range of maybe 400 or 500. But in paracetamol toxicity or acute liver failure due to viral hepatitis or in fact autoimmune hepatitis, the ALT and AST are in the range of thousands, like maybe 2000 or 3000 in fact. Also, these conditions follow a specific time frame. The duration is in fact not diagnostic, but it can give you a clue. For example, if the patient progressed from jaundice to encephalopathy in less than 7 days, then most likely cause may be paracetamol toxicity. If the progression took 1 to 4 weeks, then viral hepatitis can be the cause. And if the condition progressed over months, then it can be drug related or due to autoimmune cause or in fact metabolic cause like Wilson's disease. Lastly, I want to talk about raised ALP and cholestatic pattern. If ALP is raised, then look at bilirubin and GGT. If both bilirubin and GGT are raised too, then the elevated ALP is most likely hepatic in origin. And the first step to assess the patient would be to do ultrasound of right upper quadrant. If bilirubin and GGT are normal and only ALP is elevated, then most likely it is due to a non-hepatic source, for example bone and placenta. In that case, the causes include healing fractures, osteomalacia, hyperparathyroidism, Paget's disease, and bone mets. Now, how to proceed if there is raised ALP due to hepatic origin? On imaging like ultrasound, if there is biliary ductal dilatation too, then most likely it is extrahepatic cholestasis. And the causes include common bile duct stones, which are most common cause of extrahepatic cholestasis. Other causes can be malignant obstruction, for example, CA pancreas, and primary secularizing cholangitis. If there is raised ALP of hepatic origin but no biliary ductal dilatation, then most likely it is intrahepatic cholestasis, and the causes include viral hepatitis, intrahepatic cholestasis of pregnancy, which usually appears in the third trimester. It can also be due to total parenteral nutrition (TPN). Other causes include primary biliary cholangitis and primary secularizing cholangitis. As you can see, primary secularizing cholangitis is also causing extrahepatic cholestasis. So yes, primary secularizing cholangitis is well known to cause both extrahepatic and intrahepatic strictures. I hope you enjoyed watching this lecture. If you like this simplistic approach to interpret LFTs, then share it with your colleagues too. For more such videos and lectures, subscribe to my YouTube channel. Thank you.